Hi, my name is Brian Figler. I'm a clinical pharmacist. Today I'm going to present Dennis Brevard, who's a 52-year-old male presenting to our clinic. Analyzing Dennis's signs and symptoms in his labs, I've found that his problems include community-acquired pneumonia, acute decompensated heart failure, and atrial fibrillation. Assessing his community-acquired pneumonia, the patient presents with shortness of breath, cough with sputum, weakness, chills, and fever. He has a temperature of 101.2 degrees Fahrenheit. His white blood cell count 16,400, indicating infection. He does have an elevated respiratory rate of 29 breaths per minute, and a chest x-ray shows left lower lobe opacity. A sputum gram stain came back with gram-positive cauci. A sputum and blood culture is currently pending for the patient. He does have a curb 65 score of 0. However, we want to go ahead and treat him inpatient due to his decompensated heart failure. And he hasn't received antibiotics for the last 3 months. I want to recommend initiating azithromycin 500 milligrams IV and ceftriaxone 1 gram IV for a total of 5 days to treat his CAP. We want to continue therapy until the patient is afebrile and clinically stable for 48 to 72 hours. I want to monitor his respiratory rate daily until it is within normal limits, so less than 24 breaths per minute, as well as monitor temperature daily until it's less than 100.4 degrees Fahrenheit. The reason I went with a macrolide and beta-lactam instead of fluoroquinolone is due to the patient's atrial fibrillation. Fluoroquinolones can cause QTc prolongation, as well as there's increased bacterial resistance in hospitals. Therefore, that's why I went with my current antibiotic regimen. In assessing the patient's decompensated heart failure, he is presenting with shortness of breath, elevated respiratory rate, cough, and fatigue. He does show heart failure with reduced ejection fraction of less than 35%. The goal for the patient is 55 to 70% based on guidelines. He does show systemic congestion with peripheral edema, jugular venous distension is present as well, and pulmonary examination shows bilateral diffuse rales, which are all indicative of decompensated heart failure. This could have been exacerbated by the patient's current community-acquired pneumonia and his atrial fibrillation, as well as his elevated blood pressure, which is 155/74. His NYHA functional classification is 3 and his ACC stage C, based on symptoms upon exertion. Patient's taking metoprolol succinate 50 milligrams for AFib and daily for AFib and CHF. He's taking furosemide 40 milligrams daily for CHF and digoxin 0.125 milligrams daily for CHF and AFib. The patient is showing signs of edema, therefore I want to initiate furosemide 40 milligrams IV bolus over 1 to 2 minutes inpatient, followed by a continuous infusion of 10 milligrams per hour. We want a urine output goal of 1 milliliter per kilogram per hour for the patient. If this isn't achieved within the first 4 hours, I recommend doubling his continuous infusion dose until it is achieved. We want to monitor for resolution of the patient's edema. Upon resolution, we can discontinue furosemide therapy inpatient. Upon discharge, I want to increase the patient's dose of furosemide from 40 to 80 milligrams daily to help with his edema. Additionally, I want to increase the metoprolol succinate dose from 50 milligrams to 100 milligrams daily, getting him towards his goal of 200 milligrams daily per guidelines. And that will both help with his hypertension, congestive heart failure, and with rate control for AFib. We didn't receive a digoxin level, therefore I'd like to order a level, and with the goal being of 0.5 to 0.9 nanograms per milliliter. The patient has a diagnosis of atrial fibrillation. He has a CHADS VASC score of 3 based on congestive heart failure, hypertension, and a past pulmonary embolism 2 years ago. Therefore, guidelines recommend anticoagulation to prevent stroke and VTE. The patient is taking warfarin 5 milligrams daily. However, his INR came back at 1.8, which is subtherapeutic, with a goal of being 2 to 3. I want to increase the patient's warfarin dose by 15%. Therefore, I want to initiate warfarin 5 milligrams on Monday, Wednesday, Friday, Saturday, and Sunday, and then warfarin 7.5 milligrams on Tuesday and Thursday. Therefore, on the Tuesday and Thursday, the patient will continue taking his current pills, but he'll just take 1 and 1/2 on those days. And that should get him within range. I want to follow up with the patient in 1 week after successful completion of a full week's dosing to analyze what his INR is and make adjustments accordingly. Patient's heart rate is 70 beats per minute, which is within goal of less than 80 beats per minute per guidelines. He does show irregular rhythm. If the patient is uncomfortable with this irregular rhythm, we can recommend cardioversion or medication management. However, if he can tolerate, no interventions are necessary. Additionally, the patient is not on a statin, so I recommend 40 milligrams daily due to the patient's previous pulmonary embolism. Those are my recommendations. Thank you.